Thank you very much indeed. So, warm wishes from the UK, the nation that is currently undergoing the greatest amount of self-harm that any country has undergone in recent history. So, what I'd like to talk to you about today is really about how Stefan was talking about needing to be able to focus on return on investment. That's really, really important for all of you. But you know what comes before return on investment? What comes before return on investment is utilization of investment. So it's about how do you get your solution working in an easy-to-use way as possible. And Stefan also trailed my talk by being able to talk about how important interoperability is. And yes, in healthcare, interoperability is really, really important. So hopefully, I'll talk about a few of those things and talk about what that means, particularly as you guys who want to be developing software, what that means to you with what you're going to be developing and why interoperability is really important, and actually why HL7 Fire is a really, really big deal and is something you should really, really focus on. But first of all, I'd like to say, you know, our lifespan's doubled in the last 150 years. But which of the top medical innovations in the last 150 years actually gets the credit for this? The fact that our life expectancy is doubled. So what is it? Is it the thermometer? Is it the stethoscope? Imaging? Antibiotics? Hypodermic needle? Was it spectacles? Is it the cardiac pacemaker? Is it the CT scanner, MRI? Prosthetics and implants? Cardiac defibrillator? What is it? Is it any of those? Number 4, you think it's antibiotics. Pardon?
Hand washing.
Hand washing, yeah? You're quite close, but probably not in the way you think. So the thing which has actually allowed us to be able to double life expectancy, okay, is actually clean water. Because it's from water, dirty water, which would actually spread things like dysentery, diarrhea, cholera, diphtheria, typhoid, all a number of diseases which would kill people. But today, because of clean water, we've been able to improve it. I mean, it is still a problem in the developing countries, because we've solved this in developed countries. But in developing countries, it is still the 5th largest killer of women, is waterborne diseases. Worldwide, about 585,000 people die a year because of dirty water. So it's still a big killer. But the thing is that the digital health advances of this century will actually be powered by clean data. And it's clean data that we really, really need. Okay? And the thing is that the data is distributed, it's overwhelming, and it's in high demand. If you think about what we need to use data for today, you know, not only is it about treating a patient or treating an individual in hospital, we're also having to be able to begin to do coordination of care, which is going to be across multiple providers, multiple organizations, and that's a lot more complicated. We're also going to be doing population health management, when we're looking to be able to identify and stratify cohorts of patients based on risk and what have you. We're also going to need this data because if we want to be training machine learning and AI algorithms, because if everybody in healthcare is talking about AI and ML, aren't they? And then we need vast amounts of data to be able to train those, so then we can then go and use them on patients. But the thing is that when we sort of look back on well, we even look where we are today, that healthcare data is, all we know is typically what we have inside the hospital. But if we're talking about being able to do the things that I'm saying about population health, we need way more data. It's way more complicated. I mean, you go back even 50 years, a health system was about fixing people and getting them out of hospital. But today, how much of a health system health expenditure is based on people with long-term conditions? Around the world, it's about 75%. So 75% of all healthcare spend is on people with long-term conditions. There's lifelong conditions that people are going to have for the rest of their lives. And all of us over the age of 40 have probably got at least one. And that's just because of evolution has not yet, as we're living longer, evolution has not allowed our bodies to catch up to last long enough. So things wear out. So most of us have got at least one. And then as you add one, another one, and add another one on that, the costs rise exponentially. But if we're going to be able, we're looking to manage long-term conditions, it's not about hauling people into hospital and treating them. Because if these conditions are lifelong, when you discharge them, that condition is, they're not cured. So we need to be able to focus on a different kind of healthcare, which we're all aware of, which is about prevention. It's about behavior change. We've had speakers today already talk about how, Freddie, who with the My Sugar, was talking about how his app is helping patients themselves do behavior change by understanding what their blood sugar is as type 1 diabetics. It's about behavior. But once we're talking about how we do prevention, how we do behavior change, this is where we need a whole new type of data. The biggest determinant of your life expectancy and the number of healthy life years you live is not, and I repeat, is not your genes. It's where you live. It's your postcode or your zip code. That is the biggest predictor of how long you're going to live. So if we're going to do prevention and need to focus on areas and people we need to work with, we need to know things about where people live. We need to know things about what's their employment status. Do they have good income, reliable income? If they're on a gig, if they've got a kind of a job in the gig economy, there's a lot of uncertainty there. That makes it difficult for them to plan feeding themselves, feeding their family. Have they got work? We need to know their status from education. We need to know about things like we do need to know about their gender. We need to know about their racial background. And all these social determinants of health are the biggest things we need. You won't get those from a hospital. And we need to be able to put these together. We need to use these today. This has all got to go into this massive data which we're looking to develop. And the thing is that there is no kind of template out there for us to be able to do it. There's no package that says this is what you go and do. Because this is new. And we're still working out essentially how you do it. So the thing is, this is not easy, obviously. But when you're going and doing this, you have to be clear about how good is my data? How clean is my data? Because it's very easy for your data not to be good. And just as in the past it was recognized that in order to improve health and what have you, we need to improve the sanitization of water. We need to think about how we sanitize and improve our data. And in order to be able to do that, we need to think about two key things. And we need to think about how we cleanse data, and we also need to be able to think about another really important thing, which is the data liquidity, which is the way in which the data can flow around the system. So, clean data, it's a very dirty problem for data science. And the issue being that acquiring and cleansing data represents about 80 to 90% of the effort of a data scientist. So what can we do to be able to take that away and make that easier? Well, one of the ways we can do it is try and make sure that everybody, as we are putting this data together, we are putting data together in a standard way, using the same language and using same formats. We need to make sure that, that we are comparing apples with apples and not apples with oranges when we're putting our data together. And guess what? That is the boring world of standards. But you know what? I want to tell you that standards aren't actually boring. Actually, it's very, very interesting. But we need to think about that. Because as Sid Jain, who is a very good friend of InterSystems, says, if the data isn't clean, the machine learning tools won't give you the output of the learnings that you need. And we need the high data liquidity. So data liquidity is the ability for clean information to freely and securely flow around a care system and to where it's needed. Okay. Now, that might sound fairly obvious, and it might sound, well, what's difficult about that? Well, let me give you an example. So I'd like to ask you, what has these got in common? Which is the Great Chicago Blaze of 1871, the Great Boston Fire of 1872, and the Great Baltimore Fire of 1905. And the answers are not the fact they're all great, and all the answers also not that they all took place in America. So what these have in common is that when other fire crews from outside the city came to provide assistance, they could not help because their fire hoses would not fit the hydrants because they were a different size. And American cities had more than 600 different sizes and variations of fire hose couplings. So the sizes of the coupling and the hose plugged into had 600 different sizes in 1905. And that, ladies and gentlemen, is an interoperability problem. So what did they do about that? Well, the American legislators said, well, what we're going to do is we're going to create a national standard. And they created the Baltimore standard after the 1905 fire. And they standardized hydrant size and hose couplings to be 2.5 inches, as the British and the Americans would say. But as I'm over here, 64 millimeter diameter, which is obviously an obvious size to come up with. 64 millimeters. Anyway. However, inertia remained. Conversion was slow and still remains incomplete. And 100 years after the Baltimore fire, only 18 of the 48 most populous American cities were reported to have national standard fire hydrants. So there were still 30 who weren't using 64 millimeter couplings. And hose incompatibility contributed to the Oakland firestorm of 1991. So there we are, 86 years later, and we still seem to not learn. And we wonder why getting data to flow around the health system is actually quite difficult. Well, you can't even do it with fire hoses in America, and that should be really quite straightforward, shouldn't it? So it seems to me that standards in fire hoses are very much like healthcare standards, and healthcare standards have been made equivalent to toothbrushes, in that everybody says they've got one, but nobody's prepared to share, which I think is probably about right. So why is it so difficult? And there's a spoiler alert. It's not just a technical problem. So it's difficult. And Stefan again talked about this in his piece before mine. This has come from this quote. This is an American doctor who also did a book called The Digital Doctor, Professor Bob Wachter. He did a report for the UK National Health Service about digital transformation. I won't read the whole lot out, but he's basically saying digital transformation in healthcare is about the most complex digital transformation you can ever want to do in any industry. And it involves something called complex adaptive change, which is everybody at the front line needs to understand and buy in and take part in the change, as well as the leadership of the organization who are responsible for that organization. And this complex adaptive change is really, really difficult. And the only way to make complex adaptive change work is by everybody who actually shares a problem be involved in designing the solution to that problem. And I mean everybody. That is the true meaning of co-production. So we have to be looking at co-production of these systems. And so if we're going to solve this problem in healthcare at a systemic level, it's about co-production. But it is difficult because of typically, and it's repeating a lot of what Stefan said, in a health system, you having to coordinate and get people to do things that you have no direct control over because of hospitals are separate kind of entities. There's a huge high prevalence of collective action dilemmas. This is a really, really interesting concept used by sociologists. So a collective action dilemma is something where, as a group, everybody realizes that doing something is a good thing to do. But in order to make it happen, one of the organizations or parties involved has to incur considerable cost and gets no benefit whatsoever. So think about when you need to be able to do something like produce some documentation from one organization and send it to another. The organization that's got to provide it has to incur costs. They might have to collect extra data, all those things. They get no benefit, and it's the receiving organization that gets all the benefit. So what's in it for them? And that's why they often don't do it. Because there's no benefit. Even though they can see the benefit in terms of continuity of care, better for the patient, passing more information on, there's no benefit for them. We also have this high variability of endpoints, which We have so many old systems, which many don't even have APIs, don't have an interface. It's very hard to integrate. We also got an insistence on using country-specific standards, which makes it very difficult for vendors to be able to work to. We should be working more to international standards and different local priorities, and I won't go through that. And one of the other problems is that when health systems are looking to be able to implement these kinds of standards, there's no process for driving adoption. They think, we'll define the standard, that's enough, everybody will go and use it, and not thinking about how you get it adopted. So I should have taken no time. I've got 8 minutes left. All right. So as software developers, what I would recommend you think about is when you're looking to build your systems and you need to be able to build interoperability into those systems, because you're going to have to, as I've said, because of this is your data liquidity, it's about cleansing data, interoperability is a thing that's going to give you all these things. You need to be aware of how the standards get adopted, because this is going to affect the way in which you build your systems. Because in order to be able to make it work, there needs to be a supply push, which is there needs to be standards in place, but you need to have a demand pull, which is the demand pull from the service to say, yes, this is what I want. This particular standard is a priority. Because if you don't have those, you're always going to end up with a problem. So essentially, different localities can have different priorities, and it's got to be clinically driven and technically informed. Remember, what you're doing here is something to drive clinical benefit. And the issue being that if you have a bunch of interoperability standards, but you don't have a pull from the healthcare system, the clinicians to say, this is what I want, you get, well, I've got some standards, but kind of, who cares? You got some standards, so what? They're no use to me. But then, if you have a demand from the service, the healthcare system saying, I need these standards, but there are no standards in place, everybody will do their own thing, everybody will be different, and what they will develop will be proprietary. It will not be open. And we end up in the situation much the time that we are now. So we need to recognize that we need to balance this supply and demand, supply push and demand pull. So why is FHIR so important? FHIR is really, really important. So previous healthcare standards like version 2, version 3 were about integration inside the hospital. FHIR is about integration inside and outside the hospital, including apps and consumer engagement. That's a really, really big thing. So everything before was about just stuff going on inside the hospital. With consumerization, what have you, this is a really big thing. It also supports all interoperability paradigms. What I mean by that is it supports messaging, it supports documents, and it supports REST APIs, which is obviously what we have with the internet. Really, really important. Before, we could do messaging with one, we could do documents with another. Here, we can do all of them in one set of standards. The other thing that's really important is that it works according to the 80-20 rule. The problem with standards before were that the HL7 standards were trying to come up with a way of defining standard that met every single use case. What FHIR does is it on purpose does not handle every single use case. The 80-20 rule is about it contains 80% of the data that exists in all health systems. And therefore, the other 20%, which is less commonly used, it puts as edge cases and allows you to be able to extend using the FHIR extensions. This is why FHIR extensions are so important and is such a great thing in the standard development. because it keeps the complexity out where you need it as the use case, as the edge use cases. This is a differentiator about FHIR, which means it works, and it works for the implementers. And of course, it's built on the technology of the internet, HTTP and REST. So any computing graduate can come out and use it. And the other thing about it is it leaves the information where it resides and get it when you need it. I often joke that if healthcare had been put in charge of designing the internet 20 years ago, what it would have done, the first thing it would have said was, we will download all information onto a hard drive, and then we'll see what we can do. Because if healthcare was always about copying data and moving it to places, not about leaving it where it is, use idea of record locators to be able to go and get data when you need it. It's a big thing about FHIR. It does that, which is hugely helpful. And it's really important for things like patient safety. So think about what you can do with FHIR when, if you've got a patient who comes into your ED who's unconscious, and you need to know what's their current medications, what's their allergies, where are you going to get that from? You like to get that from a GP system, but you need to have that up to date, guaranteed. You don't want that pushed to you where it could be 2 days out of date or what have you. You need to know their current medications. FHIR, REST, real-time pull. In the UK today, we do that right now with FHIR. With the 3 GP systems that are nationally across England, we have one API across all 3 systems that gives us the same set of FHIR resources, coded and structured, to do meds analogies. That's only FHIR can do that. Oops, sorry, I've just gone the wrong way. It improves productivity as well, because a FHIR will allow you to be able to get the data that you need when you need it in a really, really lightweight way, so that people are not having to go and log into and find different data in different systems. Today, when you see nurses and what have, particularly in hospitals, looking to find data about a patient, they are logging into multiple systems, writing data on post-it notes and what have you, to make sure there's everything in front of them. But here we can improve productivity by bringing it all together. We can make sure that we can find out if a patient did have this particular lab test 3 weeks ago that's still clinically relevant, which means we don't have to have it again now, or a radiology examination, an MRI. Huge deals. You know, in the UK, again, we reckon that using this kind of capability, you can save a number of lab tests by about 10%. And also, it gives you mobility. Healthcare is all about mobility. Again, as Stefan said, we're now, even whether it's healthcare delivered in the community, whether it's in the hospital, doctors and nurses are mobile, walking around wards. We need mobile applications to be able to do this. And this is what FHIR, again, lets you do. So what does this mean for application builders? Always think about your solution will have to work inside an application ecosystem of new and legacy applications. So you need to be able to deal with the fact that there are systems out there that don't talk FHIR, that maybe not talk anything, but you need integration to do that. But build interoperability in from the start. So that is where software like from InterSystems with RS for Health, that is exactly what this lets you do. To be able to have this interoperability built in from the ground up to allow you to integrate with anything and then still work with FHIR. Are there local or national standards for interoperability? You should always stick to international ones and only extend when you must. However, you must work with the local extensions. So, for example, in the UK, we have local extensions. Netherlands, I know, has local extensions. Okay? US has extensions. So when you're building your software and you want to think about how you're going to develop that, architect it, if you want to go international, you need to make sure that when you're using FHIR, you know how to be able to go and get those extensions, which are just URLs, but think about that in the way that you've built your applications. Think about how you want to provide and consume data into and out of your applications. No healthcare application is an island. It has to be built on interoperability. And finally, think about how you can then exploit that clean data in your application, because it's clean data which is going to drive the healthcare progress of the next century, and you can be a part of it with your applications. So think about how you're going to use that and how you're going to do it. So in conclusion, the digital advances in health and care will be based on clean data. Health and care today has an insatiable appetite for clean data, for all the AI, ML, population health, care coordination. Clean data is reliant on data liquidity and interoperability. And building healthcare apps needs the interoperability in from the ground up. Build your interoperability based on HL7 FHIR. You must work with other standards. As you work with FHIR, build hooks to allow you to support your local FHIR extensions. You're going to have to deal with that when you're looking at international apps. And take a platform approach to interoperability. And this will allow you to exploit the potential of clean data and for the good of patients. Thank you very much.
Thank you, David.